Welcome to our webinar series for professionals.
Welcome everyone to this webinar on stool testing, GI 360. So I'm Anne-Catherine, co-founder of Nordic Laboratories and DNA Life, a group of companies that's dedicated to healthcare through functional medicine and personalized medicine. And the gut is very important. When we talk functional medicine, we need the foundation to function. We need the absorption of nutrients and the right food in place, etc. And that's what it's all about today, together with Dr. Julia Malkowski. So remember the tests and supplements that we're talking about, the GI 360 today. It's in focus. You can order on your VMS platform, of course, and there will maybe be some supplements that's related or relevant. I might send a link out for those with the recording, because we are recording. Last time we did a presentation where Julia presented. The record button wasn't pressed, so we had to redo it a couple of days later. So poor Julia had to redo the whole presentation on heavy metals. Some of you might have experienced that when you revisited the video. Anyway, Julia is a naturopathic doctor, and she's a staff doctor at Doctors Data, and she graduated with her naturopathic medicine doctorate and also chiropractic medicine from National University of Health Sciences. So, and she's interested, of course, in helping people and restoring health, also in her children or her son. So, and she's an excellent presenter. She speaks quick, so you might want to revisit. There's a lot to learn. She puts like 2 hours into 1 hour, and that's the exciting thing sometimes when doing these webinars. So you're up for a treat. And just another little anecdote before I pass on the stage. Then with Nordic Labs, that started like 25 years ago, the first test we actually were offering was food intolerance testing. And the second test we got on was stool testing through a lab called Advanced Access, it was called back then. And the report looked very much like the Doctors Data report looked after, because that was taken over by Doctors Data. So we've been working with stool tests from Doctors Data and the companies before them for probably 24 years. And of course, now the GI 360 is the next kid in the line. And I call it a little bit like our Rolls Royce model of stool testing, because it kind of has, it incorporates you can get PCR testing in one test and you can get culture in another one, but here it's combined, and it's actually really nice working with it that way. So that's kind of why I call it the Rolls Royce, because it's got both worlds connected in one. But of course, we're going to learn some clinical pearls here from Julia as well, and get ideas on how to interpret the report. So I will pass on the stage to you, and do your questions in the chat, and I will take note of them. So at the end, we do Q&A. And I'll just mute myself.
All right, great. Thank you so much, Anne-Catherine. So I will share my screen here. Thank you so much, everyone, for joining us today. We're going to dive right in here and talk about the gut microbiome. This is really a good thing that we're learning about. I kind of think of this as the wild, wild west of medicine, just because it's the next frontier. There's so much that we can see here. So let me just go to presenter mode here. Just one moment. Thank you. Okay. All right. So today we're going to be talking about chronic disease and the connection with the chronic disease and the gut microbiome. And we're going to see here that there's a lot we can do as practitioners to help prevent chronic disease. So the talk is a foundation for prevention. Really, foundation is really where we want to start. We can, of course, do things looking at the microbiome, like Anne-Catherine said, using GI 360 to really look and see what is foundationally occurring for our patients that have chronic disease. And you'll see by the end of this presentation, I think you'll see that it is a really good approach, and it does make sense based on physiology. So we'll learn about that today. So let's begin. All right. So today I'm going to start with a question for you all. What percentage of the national health care, this is in the States, what percentage is spent on chronic disease and mental health? So do we think it is 20%, 50%, 75%, or 90%? So if we could get some guesses in the chat here. So I'm just going to take a look here. 90, 75, 90, 90. Well, this is the educated group. I will tell you, I do not usually get a lot of 90s is the answer, but answer, yes, 90%. So 90% of healthcare expenditure is spent on chronic disease and mental health, and those two are actually linked together. So you can see really the implications here are not only for your patient on an individual level, but for society as a whole. You know, if we can help patients with these considerations, we can really alleviate a burden for themselves, for their family members, and for society as a whole, really, because healthy people do not spend a lot of money on healthcare. So we can address this, and there's a lot that we can do to actually save our patients. So helping our patients invest in prevention is really an excellent strategy for a long-term return on investment. So really helping our patients understand that you can invest in your health now, and this is going to save you long-term. Right. So what are the most prevalent chronic diseases today? Well, I'm sure you see these day in and day out in your practice. We have cardiovascular disease, cancer, type 2 diabetes, diabetes mellitus type 2. This used to be called adult onset diabetes, but we are seeing more and more children all across the world actually having type 2 diabetes. So this is very concerning. Obesity is prevalent as well. Obesity is increasing everywhere. So that's very important to understand that these chronic diseases are increasing as well. Arthritis is actually one of the most prevalent chronic disease. And we're going to weave this in with IBS, so irritable bowel syndrome, which I know you see so often in your practice. Many of these conditions are associated with IBS. Arthritis and IBS are directly associated. So the strongest connection here. And that's due to the other underlying autoimmunity and food sensitivity consideration in both conditions. Okay. And then the next one we have is type 3 diabetes. That's going to be Alzheimer's disease. And this is again connected to not only insulin, but the gut microbiome. And last but not least, we have depression. I was surprised to learn that depression is classified as a chronic and one of the most prevalent chronic illnesses. I don't know about you, but sometimes I think about cardiovascular disease and diabetes in a different category than depression. So I think we should understand that, you know, it is a chronic illness and many people are influenced and affected, and the gut microbiome does play a role here. So we can take a look at that as well. All right. So today we're going to be talking about the gut microbiome, and we're going to take it all the way back to the beginning of medicine. In the very beginning of medicine as we know it, Hippocrates, the father of medicine, stated that all disease begins in the gut. And today, with advances like GI 360, we can understand that is true. We can take a look at the bacteria and the yeast and the viruses and the short chain fatty acids in the colon and see how these microbial mediators actually influence systemic physiology. So this is a really cool time to be in medicine, that we have this tool like GI 360, and we have this age-old adage that all disease begins in the gut, and we can really take a look at it and see and help our patients. So it's pretty cool. So with regards to the gut microbiome, I just want you to take a look at this here. These are the main phyla. We're going to look at this with GI 360, but there are different phylas within the bacterial makeup. So we start with phyla, and those are the broad families of bacteria. And then you have specific species. So sometimes when you're looking at studies about the microbiome, there'll be information about phyla or there'll be information about species. The GI 360 looks at phyla and species. So we have all of that information in this report, okay? Another thing we're going to look at is the gut microbiome metabolites, the short chain fatty acids. And I'm sure you've seen these other markers such as lactoferrin and calprotectin, these inflammatory markers. And we're going to talk a lot today about microbiome abundance and diversity. And this is kind of a newer thing, a newer topic with regards to the microbiome, but it is so important and it is so foundational. If you take away one piece of information today to help your patients, it would be that diversity, healthy diversity is associated with healthy health outcomes, and decreased diversity is associated with adverse health outcomes. Every single study that you will see with regards to diversity and a health outcome shows that low diversity is not healthy for us, and high diversity is very, very healthy for us. And this can be anything from cardiovascular disease to hypertension to actually mood disorders, eating disorders, extroverted behavior. So there really is a role for healthy diversity. And that's because our colon is not unlike any ecosystem, right? So we're all very familiar with this concept that the rainforest is a diverse ecological system. And once you start cutting down trees and removing plants from there, it's not as healthy. And that's the lack of diversity. So the same concept exists in our colon. And the implications are just far reaching. So you'll probably hear more about this. Research is just kind of picking up with this now. All right. And then abundance means the amount of bacteria in the colon. And GI360 is excellent because it actually will give you a visual diagram of microbiome abundance and diversity. So you can have this information in a very palatable way. And again, balance is key with the microbiome. This is very different than, let's say, historically we had used the colon to look for pathogens like Salmonella and E. coli and eradicate them. And that's fine. We still do that. There's still a role for that. But we are able to use technology to look at the bacteria makeup as a whole and understand balance and how the balance of these bacteria plays a role with our health. Okay. And then the next point we're going to talk about today is keystone bacterium. So do you remember maybe, I don't know, like 2-3 decades ago, no one knew what lactobacillus was. Now lactobacillus is a household name. Everybody knows lactobacillus. Well, that's thanks in part to the commercialization of that bacteria, but that doesn't disregard that bacteria does play a role in human health. So that's a keystone bacteria. The other keystone bacteria we are going to talk about today is going to be fecal bacterium protenitzii. That is a key butyrate producer, very anti-inflammatory. And then Akkermansia muciniphila, which you may have heard of because I'm hearing this more and more within our medical sphere, Akkermansia muciniphila. This is a key bacteria that plays a role with mucosal barrier. And so that's a precursor to intestinal permeability. And we will talk about that today. So I think we'll hear, in the next decade or so, these other names like Akkermansia and fecal bacterium, they might be as common as lactobacillus. And then today also we're going to implore this ideology about holobiomes, and that's really looking at human physiology as not distinct from the bacteria, but as one whole consideration. So that's the term holobiomes, and we're seeing this now in medicine, and it's understanding that we are not separate from our bacteria, and they really do play a role with our physiology. And we can see that now in studies that show us that microbiome diversity actually influences our extroverted behavior, which who would have thought? So we're learning so much right now. It's a cool time to be in this field. All right, so let's talk about these specific chronic diseases: cardiovascular disease and the microbiome. Coronary artery disease is the most common type of heart disease, killing almost 400,000 people in 2019. That's the latest data. During this time that we are talking today, almost 100 people worldwide will have heart attacks. So this is extremely prevalent. There's almost 20 million adults in the world that have coronary artery disease, And this is still a leading cause of death worldwide. And we know this is a lifestyle disease with a strong nutritional component. I mean, we do know this. So it's interesting that we're in this unfortunate situation where we're sitting here talking and over almost 100 people will have heart attacks, but we know this is a lifestyle disease. We should be able to take a foundational approach and, help people to prevent this. With regards to microbiome dysbiosis, there is a connection there. Microbial dysbiosis is associated with hypertension, atherosclerosis, and heart failure. With hypertension, I would definitely take a look at short-chain fatty acids in those cases, because those are the microbial mediators that go and influence blood pressure. So, taking a look at microbiome dysbiosis and then hypertension. We'll talk about atherosclerosis next. There is a role here for an alteration in diversity and composition, and it's associated metabolites, like we're saying, those short-chain fatty acids, and there's a byproduct that we're here. So the consideration here is with aging. We know that aging is actually one of the biggest risk factors for disease. And the idea is that, over time, you're going to have reduced vascular dilation that's associated with aging, that's associated to the microbiome. So there's a role that the microbiome plays in the aging process. So if you consider that the microbiome is influencing the age of the individual, and the age of the individual is decreasing, like arterial responses and dilations and things of that nature, and vasculature and things like that. And then you have cardiovascular disease along those lines. So that's a consideration. Now, the other consideration we're going to talk about is TMAO, trimethylene amine N oxide. So I'm going to flip to the next one for that. And has anyone ever heard this idea that red meat is bad for your heart? Red meat contributes to cardiovascular disease. Has anyone heard that? The idea that you got to eat vegetarian for heart health. Well, that's actually mechanism of action actually lies in the colon. So what we have here is, in the presence of L-carnitine, when we consume that, the bacteria in our colon ferment that, and as a byproduct, they create TMAO. And then TMAO travels throughout systemic circulation, and it is associated with strokes. It kind of globs on to the arterial wall, and is associated with strokes, AAAs, myocardial infarction. So it is a consideration there. Another thing we know about TMAO is we know that when people are on antibiotics, they have less TMAO. So it's interesting to know that whole concept of red meat causes cardiovascular disease is actually gut mediated. And so the theory is, we need to look at this and see if there's more considerations with gut dysbiosis and how the microbiome processes L-carnitine to create that end product, TMAO, which results in the mechanism of action of stroke, carotid artery disease, myocardial infarction, abdominal aortic aneurysm, etc. Okay, so there is a strong gut connection here in between that idea of red meat causes heart disease. The next one we're going to talk about is cancer. So cancer does have a link in the gut microbiome. I would say this one, when we're talking about IBS, this is not associated with IBS. This is the one here that's not. We just talked about cardiovascular disease. There is an association there with cardiovascular disease and IBS. Hold on, I'm just going to go back because I didn't want to mention that. What happens is when patients have, this is the theory, when patients have IBS, that's going to lead to a decreased absorption of minerals and vitamins, magnesium, B vitamins, things like that. And then that actually contributes to hypertension and contributes to heart attack. So there is an association there between IBS and myocardial infarction. So that's a consideration there. With cancer, we don't have any associations with IBS. Really with cancer, the consideration here is that there is cancer, the consideration with the gut microbiome is essentially that the gut microbiome is the seat, the house of our immune system. And there is a role that our immune system plays in cancer. So this is the one that I'm going to say, to be determined. We can give some basic information here, but we're not going to recommend, using the gut microbiome in this way. Now, there is some evidence here that some scientists are using the gut microbiome to modulate the patient's response to cancer immunotherapies. And again, the jury is still out there. This is the beginning of this. I would definitely caution anybody that has a cancer patient or treating a cancer patient, do not use the gut microbiome approach. We're not there yet. Okay. So just understand that the potential consideration here is that the microbiome influences the immune system. With cancer, there's an immune system consideration. Right now, there's medications that are going to be potentially utilized to modulate the immune system's reaction when an individual is taking a medication. So this is the one where we have caution. And at this point, I would say, this is not for, us to really employ, but we can pay attention to this area in the future and see if there's more information. All right. The next one we're going to talk about is diabetes. Excuse me. Diabetes. So diabetes, oh my goodness. Unfortunately, diabetes just increasing exponentially. According to the CDC, almost 40 million Americans have diabetes, but more than double that have pre-diabetes. And most of these people do not even know. Wow. So there's really a role for us to catch these people. So we're not going to talk about it today, but Doctors Data offers a great cardiometabolic test, and you might be doing these tests with your patients already, right? Fasting insulin, the glycomark, things like that, to really understand what glycosylation and glucose metabolism is for your patients. Because when people are in prediabetes, that's where we want to intervene at that point before it leads to type 2 diabetes. And don't forget, this is not just adults, this is children. And this has a lot to do with the food we eat, the fructose, the processed foods. And this could be really in any country where people are consuming processed foods. We're seeing this increase all over the world. Again, lifestyle, nutrition, there's a weight influence, pathophysiology. So all these things go together. Now, type 1 diabetes, we're not really going to talk about too much, but interestingly enough, there is a study that shows that type 1 diabetes drastically increased after World War II. And after World War II is when really processed foods became the norm in the United States, this is. So the consideration is that there might be an underlying consideration with diet there as well, all right? And then metabolic syndrome is prevalent. This plays a role here. We, like I said, really test your patients for fasting insulin, glycomark, and things like that. We really want to catch these things before they go on. And the cool thing is, if we can intervene and help our patients until they prevent at the prediabetes level, people are going to be very thankful. That's a great service. So with regards to diabetes and the gut microbiome and GI 360, there's specific bacterial makeups that are associated with type 2 diabetes that you could take a look for. That's going to be the bifidobacterium, the Bacteroidetes, the fecal bacterium, Akkermansia, and the Rosebria. So those are negatively associated with type 2 diabetes. Now, I don't know if you remember, we said we're going to talk about fecal bacterium protenitzii and Akkermansia muciniphila. So we will. But fecal bacterium is extremely anti-inflammatory. So that makes sense. If it's too low, there will be potentially inflammation in the colon and then potentially diabetes. Akkermansia is associated with mucosal barrier integrity, which is very important. We'll see a little bit about that. So if that is too low, the patient may be at risk for lack of mucosal barrier integrity and intestinal permeability, but also inflammation. So those are really important bacteria that you can take a look at in your patients that you're thinking along these lines, and you could take a look at those values in the GI 360 and address them. Just very quickly, clinical pearl, but I will say it again. Fecal bacterium loves soluble fibers. So that's going to be like the red kidney beans, lima beans, chickpeas. And Akkermansia loves polyphenols. And then one red berries. But one of the most popular items here is going to be pomegranate. That one always comes up with Akkermansia. And then the other bacteria that we see in this category are going to the Ruminococcus, the Fusobacterium, and the Blotula, and those are positively correlated. But at the end of the day, there still is this role for microbiome dysbiosis and diversity. So I remember at the beginning of the talk, I said diversity is so important. Decreased diversity is associated with diabetes. Okay. And then with diabetes, we do see some patients having IBS and having diabetes. And I think that has to do with, the diet. Again, the food that they're eating is not healthy. And if they're going to have these lower beneficial bacteria, things like that. So there is a slight connection there. All right. So the next one we're going to talk about is obesity. This is very prevalent. I'm sure you see it in the US. We have 1/3 of adults and 1/5 of children. So it's, pretty, dire situation. We need to address this. According to Harvard T.H. Chan School of Public Health, prevention is really important. And these are things we already know: physical activity, diet, screen time, sleep patterns, and stress management. Okay, what do physical activity, diet, screen time, sleep patterns, and stress have to all have in common? That is something that we dealt with just a few years ago. COVID, right? All of these things worsened by all metrics during COVID. So I think that whole thing and the way that it influenced, that pandemic influenced our lifestyle, we're going to see adverse physiologic health outcomes in this regard for, maybe years to come, unfortunately. So with obesity, there is a consideration for systemic inflammatory changes as an underlying pathophysiology. So sometimes people discount this, but it's really important to understand that there is inflammation in obesity, and you can address that and potentially help the obesogenic physiology. Diet, gut microbiota, and absorption of nutrients. Again, if there's a gut microbiome dysbiosis consideration in patients that are obese, there's going to be lack of nutrient absorption. And then that lack of nutrients is going to continue to spur obesity in terms of diet. What's the word? Dietary triggers. If people don't have enough nutrients because there's gut dysbiosis, they're going to crave these high carbohydrate, these sugar foods because they're minerally deficient. They're not going to reach, unfortunately, for, the nutrient dense vegetables, but they should, but they just can't. They're just so nutrient deficient and inflamed. And one of the things that, we talked about phyla. Remember at the beginning, we talked about phyla. These are the family of bacteria. And there has been a lot of talk about the abundance of bacteroidetes with the decrease in Firmicutes. And that's fine. But actually what happened is study after study, that's not a consistent finding. So hanging our hat on the bacteroidetes Firmicutes ratio is not the best. We have better information here. All right. So what's the better information? Well, we know that there's obesity related differences at the species level. So remember I said phyla is family, and that's great. But if we can get to the species level, that's more specific. So there are specific bacteria that have been associated with diversity and with obesity. Now, there's some of these we don't look at on the GI 360, but some of them we do. So the Clostridium is associated with it, Eubacterium, those two, the Cantibacterium, in the Lactobacillus and the Actinobacteria. So these are all lower in microbiome. These are all lower in patients with obesity. Now, clinical pearl, I would say, right? Lactobacillus, we know, likes polyphenols. So the idea here is that feed the patients polyphenols, red berries, green tea to support the lactobacillus. Actinobacteria, these actually like vegetables. So feed the patient vegetables, and that would support the actinobacteria. Now, remember what we said one slide ago, that, there's a mineral deficiency consideration here. And, polyphenols and vegetables are great sources of mineral-rich foods. So we want to support those mineral-rich foods to support these healthy bacteria to address the diversity issue with obesity, okay? And again, there is that diversity issue and abundance issue as well. So low diversity is associated with obesity. Dysbiosis is associated with obesity. And don't discount the fact that the microbiome can manipulate host behaviors by changing food preferences. I mean, we know that, same thing with yeast. So you want to take a look and address this for your patient. Now, has anyone heard of fecal microbial transplant to address not only obesity, but chronic diseases? I'm sure we've heard of fecal microbial transplant from a donor to a new patient to address obesity. And we've seen some promising considerations there, right? We've seen some promising considerations. Just trying to take a look at the chat. Nothing. Okay. But what they're talking about now here, actually, they're talking about you will be your own donor. So in your young 20s, when you're healthy and robust in the prime of your life, you're going to actually take a sample of your fecal microbiome and bank it until later in life, like when you're 50 or 60. And the idea is that that will ameliorate obesity and some of these chronic, lifestyle diseases. Pretty interesting concept, right? So we'll have to keep an eye and see what develops with there. And then the other thing is, diversity does play such a strong role, even in twin studies. So if you have twins that, they have the same genome and genetic makeup, the one individual that has lower diversity has obesity. So it's really important. And of course, dysbiosis. And the wonderful thing about GI360 is there's that dysbiosis index. So we'll see on GI360, this is an excellent computed weighted algorithm. It looks at all of the bacteria, the species in the colon, and evaluates them for their levels and creates a dysbiosis index score that's individualized to your patient. And a dysbiotic gut, scores of 4 and 5 are associated with obesity, IBS, etc. Okay. And then, IBS, there is an association with IBS and obesity for sure. Now, I'm sure we've all heard of the newest weight loss injectables. Those are all the rage in the States. I don't know about Europe if those are on the market yet, but in the States, we have these weight loss injectables that are called semaglutide. And what these are is when we feed our body's in a fed state, this signals a peptide. It's called glucagon-like peptide 1 to be secreted, from the colon. And then glucagon-like peptide 1 will actually tell the brain, okay, we're full, we don't need to eat. And it will actually say, okay, let's put out some insulin and manage the food that's here essentially. Now, it lasts about 2 minutes. Endogenously produced glucagon-like peptide 1 lasts 2 minutes. But the pharmaceutical industries have come up with a glucagon-like peptide 1 that lasts for 1 week. And it's an injectable. So now people are taking these injectables to lose weight. It is studied to lose, I believe, larger amounts of weight. I think, over like the 30, 50, 100 pounds, large amounts of weight. So it is promising because, it is addressing this obesity epidemic. But recall, this is a peptide that's made in the gut. And in the gut, what we can do to support this peptide is Akkermansia eosinophila and bifidobacterium. So these bacteria, when we support them, they support glucagon-like peptide 1 production. And polyphenols are going to be really important as well. And looking at the short-chain fatty acids and GABA. So all these play a role in regarding glucagon-like peptide 1 activity. And I would just say reiterate, Akkermansia loves polyphenols, and the bifidobacterium, they like polyphenols, and they also like soluble fibers. So you could do that, for your patient to support the production of glucagon-like peptide 1. All right. And the last one here is arthritis. The second to last one, arthritis. So, I didn't really think arthritis has a good link in the gut microbiome, but actually it does because of the inflammatory consideration. So early arthritis has a reduction in certain bacteria, including the bifidobacterium and the Bacteroidetes, and a marked increase in species belonging to the Prevotella. So that is, to me, I think of dysbiosis when you talk about that. Another thing we know is that in in germ-free mice, so germ-free mice are an excellent way to understand the influence of the microbiome and systemic physiology. Because when we look at germ-free mice, we're seeing the absence of a microbiome and how that affects the implication is with that then there is a influence of the microbiome in that physiologic outcome, right? So in germ-free mice, they don't have any microbiome, and then they don't get arthritis. So then that allows us to understand, okay, there is a connection with the microbiome and arthritis, the development of arthritis. There's a dietary and inflammatory consideration. Short-chain fatty acids play a role. There is a consideration here with autoimmunity and intestinal permeability. So we'll talk about intestinal permeability next. And then of note, another connection we see here is that when drugs are used to treat rheumatoid arthritis, they also have an antimicrobial effect. So in that case, we can see that there, if it's having an antimicrobial effect, then that's potentially helping with the rheumatoid arthritis. And then patients whose RA improved also displayed improving GI microbiomes. So there is a connection here. And then again, that fecal bacterium partentia is decreased. And there is a consideration that dysbiosis precedes development of arthritis. So something to pay attention to. And then with regards to arthritis and IBS, this is a very strong connection here. And both are both are considerations with regards to inflammation and, food allergies. So there is a strong connection here. So this is in patients with arthritis, it would definitely make sense to do a GI 360 and address the underlying physiology. Now, Alzheimer's disease and the gut microbiome. Alzheimer's, this is type 3 diabetes. We know there's an insulin connection here as well. Oh my gosh, this is amongst the most common causes of death in the United States. So we are seeing this increase in prevalence, unfortunately. And right now, there is no established way to prevent Alzheimer's. Now, we used to look for the amyloid plaques. And recently, research has shown us that people have amyloid plaques regardless of whether or not they have Alzheimer's. So it's not necessarily the consideration. It might not be the beta amyloid plaques. It might be the alpha amyloid plaques. And the plaque formation is actually connected to the gut microbiome. So again, there's a role here potentially for the gut microbiome to potentially prevent this condition. And then again, we'll see this with many of the chronic diseases. If people have one chronic disease, there's a connection with another, right? So obesity, cardiovascular disease, depression, diabetes, Alzheimer's, they kind of go together in a web. Alzheimer's is linked to depression and, consider mental health early. We'll talk about depression in the microbiome next. We think about these gut microbiota as the second brain, right? So the gut-brain axis, there is a role for decreased diversity and then Alzheimer's pathophysiology. So again, microbiome diversity is very important. And then the consideration here, that mechanism is the microbiome abundance and diversity impacts neurotransmitters and neuromodulators like serotonin, kynurenine, catecholamines, as well as the amyloids. Again, remember, those plaques are connected to the gut microbiome, and this is the gut-brain axis. Some researchers believe that Alzheimer's disease does begin in the gut and is closely related to the imbalance of the microbiome. So again, microbiome diversity, that's the balance of the microbiome. We want to consider vascular pathophysiology here. And again, that's kind of going back to what we said earlier about if people have IBS and things of that nature, then they're not going to absorb their nutrients. That's going to decrease that's going to increase vascular pathophysiology, et cetera, et cetera. Okay. And then with regards to looking at the bacteria in the colon, increased Bacteroides and decreased Bifidobacterium have been associated with a negative interaction with ApoE. So sometimes we're just screening for and looking for ApoE in our patients, but consider there is a connection here with Bacteroidetes and Bifidobacterium, which you can look at in the GI 360. And again, decreased diversity. So the other thing here is like those inflammatory bacteria will look on the GI 360 at the inflammatory bacteria. So it is important to, I think, consider this. Okay. And then the last condition here is depression. Depression is definitely very common. 18 million Americans in the United States. There is that consideration with the gut-brain axis. There is the vagus nerve. We know that serotonin is actually made in the gut. That's where 90% of serotonin is made in the gut. We did have some issues recently with this serotonin hypothesis and some research saying that, maybe these SSRI drugs don't actually decrease serotonin, but maybe there is an implication actually for those SSRI drugs to decrease inflammation, and maybe that has to do with the gut microbiome. So again, jury's still out. But serotonin is synthesized in the colon, that's where it starts, but that serotonin doesn't exactly go to travel to the brain. It actually sends signals up vagus nerve to stimulate the neurons in the brain to create serotonin. So there is a connection between your colonic and neuronal serotonin. It is not direct, but it is a microbial mediator. So that's important to note. There is a strong association with microbiome and mental well-being. In depression, you'll see increased Faecalibacterium and decreased fecal bacterium Prochnitzii. That's important to note. Decreased gut microbiome diversity is associated with altered, GABA, serotonin, glutamate, and neuroinflammation. And then we're talking about IBS today. So according to a study done in 2012, 30% of people with IBS experience depression. That makes sense. Unfortunately, IBS is a very difficult condition, and people then have generalized anxiety disorder and depression. In people with IBS, diagnosed with IBS, depression is the most common mental health issue. So we want to think of these together, how we can help our patients. Okay. So we're going to take a brief moment here just to talk about gut microbiome health basic considerations. We know that diet is key. That's the foundational piece. And we talked about some specific nutrients. We talked about soluble fiber, polyphenols. We know fermented foods are excellent. We want to also assess and address the microbiome. We talked about some things, and really taking a look at GI 360 and understanding specific bacteria will be helpful. Microbiome abundance and diversity is helpful as well. And then remember, balance is key. Intestinal permeability, we're going to see a quick case of that. And with regards to microbiome health, do not forget to look for pathogenic bacteria, parasites, and yeast. And also one thing I want to talk about just briefly is the concept of eating hygiene and the parasympathetic nervous system. This goes together. So for those of us in Europe, you may be better at this in terms of eating hygiene. And that is sitting down, enjoying your food with others, smell your food before you eat it. Things like that do influence your digestion and the microbiome. So in the United States, if you're going through a fast food drive-through and you're sitting in traffic, that's not going to have your body in rest and digest, and that's going to negatively affect the microbiome. So sometimes that is actually a really important key for health in the microbiome. Okay. So we're going to take a moment here and talk about intestinal permeability. We have gut microbiome dysbiosis is associated with that. What happens is the mechanism of action is this. You have microbiome dysbiosis. You don't have the correct bacteria in there to support mucosal barrier. So then you have decreasing mucosal barrier integrity. The bacteria that are in the colon can actually now touch the colon wall, and the colon wall does not like it. It gets irritated, it gets inflamed, and you have those gapping of those tight junctions, and then you have increased intestinal permeability. This is associated with celiac disease, type 1 diabetes, juvenile non-alcoholic fatty liver disease, which is associated with obesity. There's also evidence for multiple sclerosis, rheumatoid arthritis, asthma, and in IBD. Intestinal permeability is also found in obesity and type 2 diabetes. Also Crohn's disease, and type 1 diabetes even before the development of that. So this is a very important consideration and associated with stress. So here I just want to take a look at the zonulin family protein. This is the serum test, and zonulin is a byproduct of intestinal permeability of those gap junctions. So you can easily measure zonulin in serum or zonulin in fecal and see if your patient has intestinal permeability. So that's great. And that test is antiquated. So I'm going to move on. Okay, so how do you want to restore intestinal permeability? The first thing to do is to address dysbiosis if your patient has dysbiosis, and then including these anti-inflammatory therapies, which these nutraceuticals, I bet everyone is so versed in this, but the omega-3 fatty acids, aloe vera, vitamin C, quercetin. There's also a role for nutraceuticals, zinc, pantothenic acid, and L-glutamine. And this is here for your reference, okay? All right. And so now we're going to take a look at some cases and get into the nitty gritty of this. So when we're looking at the GI 360, we want to talk about balance of the microbiome. That's very important. Abundance and diversity. We also want to look for, like we said, pathogenic bacteria, viruses, and parasites, yeast, fecal secretory IgA. That's an immune marker. Inflammatory markers are very important. And then those microbial mediators, short-chain fatty acids. And then here's some notes about the specific keystone bacteria. We did talk about these and we'll see them in the cases. Fecal bacterium proteiniceae, again, like I said, now everyone knows lactobacillus. I think in the future, these will be household names. Fecal bacterium proteiniceae is a butyrate producer. So it's very anti-inflammatory in the colon. It also supports that mucosal barrier integrity. So it will prevent intestinal permeability, autoimmunity, et cetera, et cetera. When this is low, it's associated with a variety of conditions. Diabetes is going to be one of them. And then IBS, celiac, RA, and depression, okay, that we talked about today. And then the next one is Akkermansia muciniphila. I feel like this one is just increasing in popularity. This is like the en vogue bacteria of the moment. Again, remember, this one likes polyphenols, pomegranates. This one is decreased in a low FODMAP diet. So in patients that have been on a low FODMAP diet, I would do a GI 360 and see where everything is and you can address it. This is lower in patients with diabetes, obesity, and inflammatory bowel disease. And this one is associated with weight reduction. So there's a role there, and also intestinal permeability. So Akkermansia is excellent bacteria, and we do take a look at that level on GI 360. And then the Faecalibacterium, this one is associated with mental status, depression, Alzheimer's, ulcerative colitis, and Crohn's. So if it's too low, that's the consideration. It's increased in patients with depression, but it's lower in patients that have ulcerative colitis, Crohn's, and Alzheimer's. So it's good to look at the value. This one loves cruciferous vegetables and such as broccoli. So if it's lower, you can make sure your patient is having adequate cruciferous vegetable consumption. All right. So here's the GI 360. Let's take a look at this here. Now, this first page is great for patient education. It has a lot of information, but it's fairly simple to understand. Remember, we saw at the beginning of this talk, we saw the different bacteria by phyla. Those are the families. We saw that graphic. And now we're seeing it organized here. So here are the 6 main phyla here. And then your patient's result is this white web that's superimposed on the normobiotic reference range, which is the green hexagon. So you can see right away where your patient is with regards to abundance and diversity, okay? So if this white web is a great amount of surface area, almost approximating the hexagon, that's healthy abundance. And if it's making a hexagonal type shape, that tells us about diversity. So this is moderate diversity. This is making a hexagon. Sometimes you'll see these and they will make a triangle or a square, and that's very unhealthy diversity. So this is a reasonable amount of abundance and diversity. It could be better with diversity because a clinical pearl, I'll just mention here, is this actinobacteria that's first phyla on the top left corner. They really like vegetables. So this is lower. So I would think about vegetable intake for this patient. And then the proteobacteria, these are pulled down. So this is higher as it goes towards the red. And those are inflammatory bacteria. So I would think about what the patient's eating. So, diversity could be better. Abundance looks reasonable. And then you'll take a look at the scores. And the scores are excellent information because this is computed algorithm of 45 different analytes. And we have the dysbiosis index is 3, it's moderate. Diversity score is 2. So you could increase diversity. We already know increase vegetables and decrease processed foods. Okay. And then here's, again, like I said, it's analyte by analyte. And I'm going to go through this a little bit quick in time. So our first case is this was brought to us actually by a psychiatrist. So this is a functional medicine psychiatrist who's using gut microbiome testing in their patients. The patient was switching from a processed food diet in the past 3 months and lost 20 pounds, has lifelong history of depression and obesity, and has had 3 rounds of antibiotics for H. pylori. So if we take a look at this microbiome, abundance and diversity, this looks moderate. Diversity looks moderate. It's making a hexagon reasonably. It's a reasonable amount of surface area. So let's see. Dysbiosis index is 3. So we're not significantly dysbiotic, but we could still help with the specific bacteria that we see. And diversity score is 3. So that's moderate as well. And here we look at the analytes for this patient. Remember, low fecal bacterium is associated with depression. So we want to help this patient here. So we want to add soluble fiber to support the fecal bacterium prognosii for this patient, okay? So that will be really important. And then the next thing we see is the proteobacteria and Escherichia species. These are inflammatory, and so you want to decrease these. So you want to talk about the patient's intake of fats, meats, processed foods, things of that nature, and decrease those. So this was a good one. And there was some positive improvements with the dietary recommendations. Okay. Our second case here is a 26-year-old female, and I'm sure you've seen these in your office, these women that have had lifelong history of digestive issues, have been to many, many doctors with no relief. She saw like an Instagram video about intestinal permeability, and she thinks she has that. So let's take a look. Okay. So the first thing we see here is this web, abundance and diversity. This is reasonable. I mean, it's a good amount of surface area. It's not quite making a hexagon. So I think about actinobacteria. We need to add vegetables. That would be the one thing I'm thinking now, but the scores are moderate. So we could improve both of these. Let's take a look though and see if we get more info here. Oh, wow. So when we look at her key findings here, so the way the report is organized is this first column is key findings, and these are the bacteria in functional guilds. So these are specific bacteria within the colon that are associated with this function. So butyrate producers, gut barrier protective, gut intestinal health markers, inflammatories, or the balance between the protective versus the opportunistic, okay? And then the second column is independent findings, the C. difficile, the carbohydrates, secretory IgA, or beta-glucuronidase. So those are independent of the first section. So the first section is about the bacteria that are making up the score of dysbiosis and diversity. So these are the functional guilds, specific bacteria associated with this health outcome. So the way it's organized is it gets more and more detailed. I'm just going to go back to show you. So here we're talking about broad phyla of the bacteria, and we're looking at your patient's web on the normal biotic range. And then we have these computed, weighted algorithmic scores. Again, very individualized medicine for your patient. And then the last thing we have here is the specific bacteria. So with the butyrate producers, we're looking at a few bacteria associated with butyrate production. For this patient, they are imbalanced. So you're going to want to give soluble fiber at 8 to 15 grams per day. That's red kidney beans, lima beans, chickpeas, things like that. And then look, the gut barrier protective bacteria are off. So that means Akkermansia eosinophila is low. So we need to give polyphenols. And then also you can do your own mucosal barrier consideration here. L-glutamine, marshmallow, things like that to support mucosal barrier. Intestinal health markers are low. So there's going to be the bacteria that prevent inflammation are too low. So we want to support those with polyphenols. The pro-inflammatory bacteria are technically okay, but then the balance between these opportunistic bacteria and the protective bacteria are off. So you really want to help this patient. Soluble fiber, polyphenols, mucosal barrier support, and maybe like an you could do something to decrease inflammation like cod liver oil, olive oil, things like that. Okay. So the next findings we'll see for this patient, there is a C. difficile detected. So we want to address that further, but I want to mention this, the carbohydrates here, the carbohydrates can be a sign of intestinal permeability because when carbohydrates are not absorbed in the small intestine, we see them in the colon. So the fact that the patient has carbohydrates and then the gut barrier protected bacteria are outside the reference interval, I would think about intestinal permeability for sure for this patient and help address that. The low secretory IgA can be remediated via vitamins A, D, and zinc. And then beta glucuronidase is too high, so the patient's going to be at risk for reabsorption of toxins, and we're going to address that with adding soluble fiber and things like that. And you can use DIM in a female if you want to. All right. So if we take a look at her bacteria, remember we said Faecalibacterium protnitzii, this is a key bacteria. And this bacteria loves the soluble fiber. So we need to feed it soluble fiber. But when this is too low, the patient's going to be at risk for inflammation. And then we talked, one I just want to mention here, the Ruminococcus navis at the end here. This bacteria is associated with mucosal barrier integrity. So when it's too high, there's an issue there. Okay. And then we saw the patient had the C. difficile. This is the pathogens portion of GI 360. This is page 5. It is highly sensitive and specific. I'm sure we're familiar now with PCR from COVID testing. A patient can test positive after the resolution of infection. And so you want to make sure if your patient's symptomatic, you will treat this. If not, they can be an asymptomatic carrier. And so that was the case, for this patient, asymptomatic carrier. And the issue really is this intestinal permeability. And so we can see here, the carbohydrates are positive because they're not being absorbed in the small intestine, and her secretory IgA is too low. So we're going to support that with vitamins A, vitamin D, zinc, and then the beta glucuronidase is too high. We don't like that. We're going to add soluble fiber, vegetables, and maybe some DIM to support the conjugation of toxins to be eliminated properly. All right. And then our third case is, maybe relate to any one of us. This is a very busy functional medicine DO, runs a very busy clinic, online practice, running this test on herself before her patients, no GI complaints, 57-year-old female. So let's take a look. Wow, this diversity score, look at this. This is making like a triangle here, okay? And what do we see? Diversity score is 1. And we know low diversity is associated with so many adverse health outcomes. So you really want to support this diversity, okay? And this is a good case because you can see it's making like a rectangle there. All right. And then when we look on specifically for this patient, the butyrate producers are low, the gut barrier protective bacteria are low, the inflammatory bacteria are too high. So there's a lot you can do here. Again, support butyrate with soluble fiber, support those gut barrier protective bacteria with polyphenols, and then use like an L-glutamine, your own specific protocol, decrease these inflammatory bacteria. Sometimes people are just eating on the run. You don't have time to make healthy foods. You have to make time for that, okay? The patient's elastase is low and her butyrate is low and her total short-chain fatty acids are low. And that makes sense because the butyrate producers are low, so the butyrate's low, and that's going to lead to inflammation, okay? And then this is, again, just showing us that major butyrate producer, Faecalibacterium protnitzii is low, and we're going to add soluble fiber. And these are other butyrate producers that are low as well, okay? And then her butyrate and her total short-chain fatty acids are low. We want to support these with soluble fiber, polyphenols, okay? So this patient doesn't have any conditions yet, but she's at high risk for it. And then lastly, a quick case here. This is going to be a CSAP, but I just wanted to show you the levels of the lactoferrin and calprotectin. So this is a 22-year-old female with no symptoms currently. She has a history of childhood RA. We talked about arthritis in this talk. She has a history of Crohn's and a history of seizures. She's currently tapering her medication for seizures, and she has no symptoms. So this is the CSAP. This is our old test, but I wanted to show you the levels of the other markers. But here, these are the expected beneficial flora. These are within range. I would have loved to got the GI 360 information on this patient and see her dysbiosis index and her diversity score. I'd be very interested in that. She has yeast, really incidental finding under the microscope. But let's take a look at her stool chemistries. So elastase is very low. So she's not putting out any pancreatic enzymes to support digestion. So we want to do that. But look at her lactoferrin, lysozyme, and calprotectin. So we wanted to talk about IBS today. In IBS, you'd really just see this lysozyme elevated. You don't see the lactoferrin and the calprotectin. When the calprotectin's at 3,536, that to me thinks IBD active. And what happened is with this patient, she doesn't have any symptoms, but she did this test, and these levels can elevate 1 month before the onset of symptoms. And so that's what happened here. All right. So at the end of the day, to wrap it up, we talked about, I'm just going to reiterate, fiber is so important. Soluble fiber, 8 to 15 grams per day, fermented foods and polyphenols, mineral-rich foods, and then those anti-inflammatories, olive oil and fish oil. All right. And again, like I said, these things are connected. Lifestyle, chronic disease, microbiome, consider abundance and diversity, test this microbiome, address and consider the microbiome as a foundation for health. Thank you. Any questions?
There was lots of questions. Lots, and the comment area was just like very active, which is very nice, because then we feel that we are together and learning together. So I just jotted them down. It may not follow the structure that you had. So one question was, can you actually selectively increase or decrease certain species? And as you said, like with polyphenols, it's the Akkermansia, and the fecalis bacteria, it would be like lentils, legumes, etc. Has Dr. Data created like these are the foods for which bacteria too?
Yeah.
A cheat sheet. That would be nice.
Yeah, good question. We don't have a cheat sheet, but exactly like you're saying, I tried to highlight those clinical pearls throughout. I would say, the foundational piece is the soluble fiber, and that helps so many of the bacteria, but specifically those butyrate producers like the fecal bacterium. And the recommendation is 8 to 15 grams of soluble fiber per day. And that's exactly like you mentioned, those lentils, red kidney beans, lima beans, chickpeas. And then there's other bacteria that prefer polyphenols, and that's going to be like the red berries, the green tea, the grapeseed, and that's the lactobacillus and the Akkermansia. And then some bacteria prefer cruciferous vegetables as well. So, and that information is in GI 360, but those are broad guidelines, but the good thing about the bacteria is when we feed them, they communicate to one another, the healthy bacteria, to stimulate their growth as well. So they work together as a whole.
And actually, just a little side note on that. I know that the nucleotide product that's in VMS, that is shown to increase bifido count. So just a little side note on that. Then another question came up on how does menopause or perimenopause impact the microbiome?
Mm-hmm. Yeah, there is a connection there with hormones and the gut microbiome. I don't have specific information on menopause, but I believe there would be association with decreased diversity. I would, of course, look at that beta-glucuronidase level and, the levels of estrogens and progesterone themselves. Yep.
Okay. So then, a question came up in the beginning about the microbiome and colon cancer. Is there no connection there? Or?
Yeah, so Bacteroidetes staphylococcus is associated with, colon cancer. I would just caution using GI360 for that purpose. The other one is mucus in the colon is associated. This is not a diagnostic test for that. I would consider following the guidelines for colonoscopy in addition to the GI360.
Okay. And then there was, because like if you Google phosphatidylcholine, and just like you said with meat, it increases T Mayo. Can you comment on that? Because that's a good thing to get phosphatidylcholine for the nervous system, etc. So
yeah, so choline and L-carnitine, right? So the consideration is, I would say the consideration is just making sure the microbiome is healthy, because it's a byproduct of microbiome metabolism. So, that's the consideration. I'm not going to say 100% that is the solution. I mean, we'd like to have more studies to see that. But the microbiome is the connection between the choline and the carnitine and TMAO.
Okay. And then if secretory is high, of course, treat the cause. So if the cause is a dysbiotic flora, or other like inflammation, autoimmunity going on. But if you see high secretory IgA, what would be the best treatment strategy for that?
Exactly like you're saying, you need to treat the cause. There's nothing to decrease secretory IgA on its own. It is treating the cause.
Okay. Then Marlene asked, you might have to help me here a little bit in the writing. Does low akkermansia result in a reduction of semaglutides, or do we bypass the gut with semaglutides? I'm not sure I completely understand the question, but I think it was important. And
yeah.
Okay, I can try and unmute you, Marlene.
You said that this GLP-1 is produced in the gut by itself. And then I was thinking, if we have, I see a lot of the insulin resistance and stuff, and the low in the semaglutides, in that production. So it makes sense totally. But if we take the injections, do we bypass the gut and have the full effect? Or if we are low in the diversity, will we get lower effect of the injections?
Okay, good question. I believe that you're bypassing the gut when you give the injection, because you're giving that GLP-1, but they've attached it to something, so it stays in circulation for 1 week. So if, like what we talked about, is if you feed the colon and you have proper akkermansia, it's going to produce GLP-1, but that is only going to last for 2 minutes.
Yeah. Thank you.
Mm-hmm. Yeah, good question.
And you actually had another one, Marlene. Let's do it right away before we mute you. It was E-Halley, if that was important in regards to insulin resistance.
Eubacterium hallei with insulin resistance. I don't know that off the top of my head.
Okay, super. I think that's, I'm going to call, I think you say, and finish it up. You've had presented a lovely theory and excellent cases, and then we had time for Q&As at the end. And of course, we will be sharing the recording, sharing the slides. It's a nice, I believe the slides are a nice curriculum to have on the side when you interpret the results. So if you do any education, etc. So thank you very much, Julia, as always, for sharing your brain with us and your experience and your knowledge. Thank you very much.
Thank you so much. Thank you,
everyone out there. Thank you for joining us. Thank you for making it fun and lots of people, etc. Have a lovely evening, day, night, wherever you are. Bye.
If you do not already have an account with us, please contact our team and we will assist you. If you found this webinar helpful, please like and subscribe to our channel.